with me is Rupert Leong from Sydney. I'm CJ from Singapore. And it's my real pleasure to introduce the JGHFoundation APDWF Emerging Leader Lecture for the Luminal section. So the award winner is Julajak, Limsrivilai. And please step up. And he's a really good friend. And he's been a leading advocate in the IBD education and research, both in Thailand and really in the region. You know him very well. He born, bred in Thailand, of course, but educated in Mahidol, and really has also cut his research skills in UC Michigan, and also had stints of training in Australia. So he's going to tell us about differentiating Crohn's disease from intestinal tuberculosis, the current challenges and future direction. Prof.
I'd like to thank the committee for giving me this opportunity. It is my greatest honor and pleasure to be here today. And this problem is very important in our region because, as we know, the incidence of tuberculosis is still high in Asia, and the incidence of Crohn's disease is increasing. And this could lead to the misdiagnosis, which has been well reported from Asan University, where they report that 18% of patients with Crohn's disease were initially misdiagnosed with TB. However, the rate declines over the time. But in contrast, the rate of misdiagnosed patients with TB as Crohn's disease, although it's lower, but the rate is increasing. And this is very important because misdiagnosing intestinal tuberculosis as Crohn's and giving immunosuppressive agent can cause disseminated tuberculosis, which is life-threatening. In contrast, misdiagnosed Crohn's patients with tuberculosis may be safer, but it could delay diagnosis and leads to Crohn's disease complication, which has been reported by 2 cohorts from India. Therefore, making the right diagnosis as soon as possible is needed. And in this lecture, I will propose the strategy that we can use, and there are 3 steps. The first 2 steps are the steps that we try to maximize the currently available investigations that we use to differentiate these 2 conditions. And the third is the step for the future investigation. Let's see the first one. To diagnose intestinal TB, there are 2 ways. The first is the conventional way that we all do, which is endoscopy and taking tissue biopsy. And the second is the other investigations that can detect TB at other sites, and we use them as an indirect evidence for intestinal tuberculosis. So let's see how to do endoscopy and biopsy appropriately. So to maximize the yield, there are 2 questions: how to take the biopsy correctly, and which investigations should be sent to detect tuberculosis. How to take biopsy, there are 4 sub-questions. The first is how many biopsy? Do we need to take biopsy from multiple sites? Do we need to take biopsy from normal mucosa? And where should we take biopsy? For the number of biopsies, based on the systematic review in 2010, experts recommend at least 8 biopsies should be performed, and this recommendation is supported by a more recent study. Professor Desai from India reported that increased the number of biopsy from 4 pieces to 8 pieces could increase the diagnostic yield of mycobacterial tuberculosis culture from 40 to 53%. And how about the size of biopsy? This is the study from India, Professor Pulimut. And as you see in the graph, the x-axis represents the size with endoscopic lesions, and the colors represent the size with positive histopathology. And as you see in the red color, many patients, although they had multiple sites involvement, only one site biopsy was positive. So which means that we should biopsy from multiple sites involvement. And how about the biopsy from normal mucosa? The same study shows that if we biopsy from the normal-looking mucosa, some significant findings, especially in patients with Crohn's disease, can be detected. And all of this evidence lead to the guideline recommendations, which they recommend in the same direction, that we should biopsy from multiple sites and from both normal and abnormal mucosa. And where should we take a biopsy? Experts recommend taking biopsy from the edges of ulcers and abscess erosion to maximize the possibility of discovering granulomas. So here's the summary of how to take biopsy. And next is which investigations should be sent to exclude tuberculosis. Basically, we sent the specimen for pathology, AFB, PCR, and culture. And how about their performance? So I will show the results of the meta-analysis from my group, which recently have been accepted. We included the studies using colonoscopy with tissue biopsy for diagnosing TB. This study includes 55 studies with over 6,000 participants. Let's see the first one, pathology. The presence of caseous granuloma is widely accepted for diagnosing tuberculosis in our region. However, the pooled sensitivity is only 18%. And the results usually come back within 2 or 3 days. And how about acid-fast baseline? The pool sensitivity is lower, only 12%, because of the bacillary nature of this bacteria. However, the result can come back within 1 day. And how about the PCR? There are 2 main methods for PCR techniques. The first is the method detecting only a single gene, IS6110, and the second is the method that can detect multiple genes. The overall sensitivity is 58%, and it is higher for the method detecting multiple genes at 79% compared to 44%. And the results can come back within a day as well, so PCR is the good test. And how about mycobacterial culture? There are 2 types of the culture media, the solid media, which is a conventional one, which grows the bacteria slower, and the liquid media, which grows bacteria faster, but maybe had a higher contamination. The overall sensitivity from mycobacterial culture is 23%, and it is higher for the liquid media at 25% compared to 6% for the liquid solid media. And the results usually takes 6 to 8 weeks for the final results. So as you see in this table, the sensitivity of each test seems to be low. And how about their combinations? Many studies report that if they combine the histology with culture, it can increase the sensitivity. And I confirm this result based on the study from my hospital, that the combination of the tests has the highest diagnostic yield over each test alone. And interestingly, in my cohort, significant number of patients, 12%, positive only from culture. So although the sensitivity overall is low, but they all complementary, and we should send our tissues to all tests. This is the summary for how to do endoscopy and take biopsy. And if the result is positive, we can treat tuberculosis. And how about other investigations? The test to detect tuberculosis at other sites includes IGRA and CT chest, which is widely available. For IGRA, there are two types, T-spot TB and quantiferon TB Gold. The overall sensitivity for IGRA is 86% and is higher for T-spot TB compared to quantiferon TB Gold. For CT chest, there is an evidence from a cohort study from India that they enrolled 200 consecutive patients with suspected intestinal tuberculosis. Of this, 88% underwent CT chest. And 17% of 88 were diagnosed TB based on the presence of caseating granuloma and necrotic lymph nodes. In 71%, they diagnosed TB based on the response to anti-tuberculosis treatment, and 48 had intestinal TB. Of these, 20 had active TB on CT chest, which means that CT chest would increase the diagnostic sensitivity from 26 to 57%, so it could be helpful. And is there any evidence using all of this investigation to differentiating these two conditions? There is a study from Professor Hilmi from Malaysia that they use all the investigations to detect tuberculosis, and if any one of them was positive, they diagnosed TB and treated. And in the result of the prospective study in 164 patients, they correctly diagnosed 90% of the patient. And only one of 30 intestinal TB was misdiagnosed with Crohn disease, so results good. So let's come back to the diagram that if we use other investigation, including IGRA or CT chest, and if it is positive, we can empirically treat TB. However, the risk of Crohn disease of TB still remains, although all the tests are negative, and in many centers, they don't have all the investigations. So many doctors try to find the significant parameters in differentiating these two conditions. And that result in the many models have been reported in differentiating these two conditions. And I reviewed this and published 4 years ago. And I noticed that many models integrate different variables. However, many variables are presented in many models, which means there must be some variable which are real significant. And this is the example of clinical and endoscopic findings. And this is the reason that I did the meta-analysis objecting to try the significant variables in differentiating these two conditions, and I classified this variable into 5 groups. And here are the results in dot plots. For the clinical manifestations, male gender, presence of hematochezia, perianal disease, and extra-intestinal manifestations strongly favored Crohn disease, while the presence of fever, night sweat, lung involvement, and ascites favor intestinal tuberculosis. For endoscopic findings, longitudinal ulcers, cobblestone appearance, skip lesion, and left side colon involvement favor Crohn's, transverse ulcer, patulous IC valve, and right side colonic involvement favored intestinal tuberculosis. The presence of focally enhanced colitis on pathology favor Crohn's, and the presence of confluent granuloma, large granuloma, submucosal granuloma favor intestinal tuberculosis. On CT, short segment involvement favor TB, while wall stratification, presence of COMSI, and fibrofatty proliferation favor Crohn's, and presence of IGRA favors TB. And I bring all of these significant parameters to the formula that can calculate the probability of intestinal tuberculosis based on the relative prevalence of these two conditions in each area, multiplied by the magnitude of the presence or absence of each finding. And this is how the model looks like. And I validate this model based on the data from 2 countries, and thanks all the others that help and support this study from Thailand and Hong Kong. And we included 590 patients. However, because it is a retrospective study, only clinical endoscopy and pathfinding were available to be reviewed. And the results shows that the model includes more significant variable, which is clinical endoscopy and pathology performed the best, with an area under ROC of 0.887, which is very good. However, some problems still remain. The first is there are still significant number of intestinal tuberculosis patients that would have been diagnosed as Crohn disease with the best model. And in many centers, there are no experienced GI pathologists and radiologists to interpret the finding as the specific findings that we use in the model. So these are the reasons that I think if I include only clinical and endoscopic finding and with the presence of IGRA, this could be helpful, and all of these variables, we can obtain them by ourselves. And I have a good opportunity to participate in a group of researchers leading by Korean Association Study of Intestinal Disease, or CASIS, and Professor Julajak came in later. And we are doing a prospective study to validate the model. And up to present, we have enrolled 122 patients. Some patients were excluded because of other diagnosis and incomplete data. And we have 90 patients at this time to be validated. And the results show that the model integrating only clinical and endoscopy findings showed the significant difference of the probability of TB between the patients with TB and Crohn's, but you can notice the overlap between these two groups. And when we include IGRA, it seemed to be better with more statistically significant. However, the overlap still remains. And if we look at then an ROC curve, you can see that the model integrating IGRA performed better, but not statistically significant. The area under ROC is 0.77, which is good, but it's not excellent. So we may need more investigations to diagnose these two conditions. However, the model is still useful, and if it suggests TB, we can do empirical treatment, and we have to follow up the patients because the patients with TB will respond to the treatment very well within 3 months, but in Crohn disease, they can show some clinical response in 1/3 of the patients, and it is important to confirm the response by endoscopy. And let's get back to the diagram. For the model, if we use and suggest TB, we can do empirical treatment. But there are still some limitations, as I mentioned. So we need better investigations, which I will present from now. The first one is the new method to detect tuberculosis. This study is published this year. They use targeted next generation sequencing to differentiating these two conditions in the patients with positive IGRA and undetermined ulcers from the right colon. They obtain the tissue specimen and send for next generation sequencing and for other investigations too. and they diagnosed intestinal TB based on the response to anti-tuberculosis treatment. And the results show that targeted next generation sequencing has a very high sensitivity, 83%, which is significantly higher than AFB TB PCR and caseous granuloma. So it is promising. And how about other investigations? So currently, we have to think about artificial intelligence and other advanced molecular tests. Artificial intelligence can be the most promising one because there are a lot of studies published in the recent years. And different systems evaluate different modalities: endoscopy, imaging, histology, or multimodality. Let's see the results for the system evaluate endoscopy findings. And in this group of AI, some systems can evaluate still images, and some systems can evaluate both still images and videos. Let's see the group that evaluates still images. The first system is from Yonsei University from South Korea. They use convolution neural network based on the ResNet-34, and they show the accuracy of 70% in differentiating Crohn's from TB with an area under ROC of 0.78. The second is from China. They use the few shot learning model and show a good accuracy as well, but they did not have the validation set in their study. And the last is published this year from Asan Medical Center. They use UNet model equipped with ResNet-50 encoder and shows a very higher accuracy of 81.5% with an area under ROC of 0.87. And they also demonstrated that AI can improve diagnostic capability of GI fellows. And now let's move to the system that can evaluate both images and videos. The system is from Nanfang Hospital University. They have 3 cohorts in their study, and they use multi-class contextual classification model, which can diagnose benign conditions in the colon, including ulcerative colitis, Crohn's disease, ischemic colitis, and intestinal TB. And as you see, the performance based on area under ROC and accuracy is performed very well for UC, ischemic colitis, and normal, but the performance is dropped for Crohn's and TB. And from the confusion matrix show that significant numbers of patients were misdiagnosed between these 2 conditions. And even they used an video levels, which improved its accuracy. Significant number of patients with Crohn and TB were still misdiagnosed. So we may need a better system to solve this problem. And how about the system using imaging from cross-sectional imaging? The study from China used the deep residual convolution neural network on ResNet-50, shows good accuracy around 80%. And the study from China as well evaluates the pathfinding, but from the surgical specimens, not from the colonic biopsy. It showed accuracy around 80% too. So you can observe that the accuracy of each AI system is around 80% based on one modality. And how about if they combine multi-modalities? These 3 studies show that a combination of many modalities and use AI to diagnose these 2 conditions performs better. They show an accuracy around 90% and an area under ROC over 0.9. So this is very promising and should help us in the future when they become more available and more externally validated. And how about the advanced molecular tests? We have immunologic profiles, proteomics and metabolomics, and microbiomes. I will show you some studies that are interesting. The first is about immunologic profile. This study shows that the proportion of CD4/25 FOXP3 T cell in peripheral blood increases in intestinal tuberculosis. And they reported this first in 2018 and validated this finding in 2021. However, the performance drops a little bit for the validation. The next is the metabolomics. This study is from China. They use 5 serum metabolites that shows in the slide. And these 5 metabolites can differentiate Crohn disease from other conditions very well, as you see in an AUROC curves between Crohn's and UC, Crohn's and TB, and Crohn's and Behçet disease. All are very high, over 0.95. So this is very promising as well, however, still need to be validated. And how about the microbiome, which is very popular at this time? This study, however, a small study, includes the 16 Crohn disease and 6 TB and use only 16S rRNA sequencing. It shows that there is a significant difference between these two conditions at phylum level, family level, and also genus level. So this could be helpful too, but need more studies with larger sample size. So let's get back to the diagram. In my opinion, artificial intelligence can help us in the future for advanced tests because it may be not available in many centers. We need more data before establishes as the diagnostic tools. So this is a summary of my talk. And I would like to thank my teacher from Julajak Hospital and also Professor Peter Higgins from University of Michigan, who always teach and support me. Thank you very much.